Crawford, and I'm a Program and Policy Analyst at the National Alliance to End Homelessness, and I will be hosting this wonderful webinar today. So for those of you who are not familiar with NAEH, we are a nonpartisan, nonprofit organization committed to preventing and ending homelessness in the U.S. So today we have a full list of excellent speakers who will discuss what's happening around the country and what can be done to address the intersection of homelessness and the opioid crisis. And as you can see on the slide, a list of our participants. So we have today USICH, SAMHSA, CSH, the City of Philadelphia, Pathways to Housing PA, Prevention Point, and Healthcare for the Homeless. So I just have a quick administrative note and we can begin because we do have a full list of speakers. If you have any questions, you can see the example from the slide. Just please type them in and hit send. We will most certainly try to get to as many questions as possible at the end. So I just want to thank you for participating and let's begin because we do have a full segment. And so we will start with Britt from USICH. Thank you.
Good morning, everyone, and thank you to Sean and the Alliance for having me on today. My name is Brittany Manzo, and I'm a policy advisor here at the U.S. Interagency Council on Homelessness. In 2016, USICH developed an interagency working group on the intersection of the opioid crisis and homelessness in order for us to navigate this intersection with our federal partners, but more importantly, to ensure that federal resources that are marshaled to address the opioid crisis not only reach, but consider and meet the needs of those experiencing homelessness. So I'm here today to offer a very quick overview of this intersection. So I'll start with what we know. Next slide. National data on the scope of opioid misuse among those experiencing homelessness is lacking. We don't have the national data, but we do have strong anecdotal evidence from providers and community leaders from across the country, as well as local studies that paint a very vivid picture. A groundbreaking study found that drug overdoses are the leading cause of death among people experiencing homelessness in Boston. 81% of those deaths were opioid overdoses. The same study found that when compared to the broader population, people experiencing homelessness were 9 times more likely to die from an overdose than those who were stably housed. Next slide. In addition to local studies and insights, we know quite a bit about the dynamics at play for people experiencing homelessness who struggle with opioid misuse. It's important to lay the groundwork here regarding the intersection of health and housing. Researchers and practitioners have identified social determinants of health that encompass all of the factors that affect the conditions in which people are born, able to grow, live, and work, and the conditions in which they experience aging. As you all likely already know from your experience, housing, or the lack thereof, is a major determinant of health. So when we're developing an understanding of the intersection of the opioid crisis and homelessness, it's critical to have this connection between health and housing at the center. Demonstrating this interplay, we know that individuals with opioid use disorders have an increased risk of housing instability. And we know that those who are experiencing homelessness who have OUDs are at greater risk of death from overdosing than their stably housed counterparts, as we saw in the findings from Boston. Further complicating these risk factors, we know that there's a significant prevalence of co-occurring behavioral and physical health illnesses among individuals experiencing homelessness. Next slide. So recognizing these dynamics, USICH and our federal partners developed a guide to 5 key strategies to support communities and providers as you navigate these challenges. The guide starts off by framing ways for communities to assess the prevalence of OUDs and opioid misuse among individuals experiencing homelessness so that other strategies can be tailored accordingly. Second, we encourage communities and providers to develop and implement or expand access to overdose prevention and response strategies, particularly the use of naloxone to counter opioid overdoses. Third, we know that strengthening partnerships between housing and healthcare providers to provide tailored assistance for individuals at this intersection is critical. Once those partnerships are in place and once a shared understanding of the scope of the intersection is built, that's when we're able to approach strategies 3 and 4. Improving access to evidence-based treatment, particularly medication-assisted treatment for this population, is critical. And finally, removing barriers to housing, offering access to permanent housing options, and implementing housing first approaches with few to no treatment preconditions or other unnecessary barriers will help individuals establish housing as the foundation upon which they can build healthier, more stable lives. Check out our website at usich.gov for more on these strategies, as well as a few case studies of best practices, including one from Pathways to Housing PA, who we're going to hear from shortly. To build on the community-wide strategies that I've just talked about, I'm going to turn it over to my colleague, Barbara DiPietro, to talk more about the individual level resources that are necessary to address folks at this intersection. Barbara, over to you.
Thanks so much. I just know that we'll be talking more deeply about the resources that are available from SAMHSA today, and we've got our colleagues here from that organization. But just wanted to, if we could get the next slide, just to talk real quick about the role of Medicaid. There's so much to say about Medicaid, and just trying to get the next slide, if we could advance that. Just because health insurance itself, so Medicaid really is a health insurance program, as many of us know. It's critical for paying for the treatment that is so often needed. It also will pay for the other medical care that is often co-occurring with addiction disorders. This is the most common insurance that's available to people who are experiencing homelessness. Medicare may be an option as well for people who are elderly or who may be dually diagnosed, or rather dually eligible with a disability, so Medicaid and Medicare are working together. And for those who are working like above poverty and have wages or may be connected to work, private insurance may be an option. But for the most part, Medicaid is really this singular health insurance program that's going to cover this population. We know that eligibility for Medicaid can vary widely, particularly based on whether on which state someone is living in. And eligibility is a state-level decision, and we still have 19 states that have not expanded to single adults without children. And so this is a population in particular that's at risk of opioid addiction. So just one action item just thinking about is making sure that everyone that you're working with is screened for eligibility for whatever health coverage they may have. And then I just want to highlight at the bottom, our partners at the Kaiser Family Foundation put some great resources together about Medicaid's role in opioid epidemic. So that's a quick just snapshot of Medicaid and that role there. There's a lot more to say there, but we'll move on real quickly. In the next slide, I just want to talk a little bit about the role of HRSA and health centers. So as the National Healthcare for the Homeless Council, we're working primarily with federally qualified health centers that serve people experiencing homelessness. These are places where comprehensive primary care is available, often coupled with behavioral health treatment that includes addiction and mental health. There's about 300 of those health centers that have got specific grants targeted to people who are homeless. And these are typically models that will be lower barrier, more focused on harm reduction, and really being able to tailor to the unique needs of people without stable housing. I know we'll talk a lot more about the resources available through SAMHSA, but just want to acknowledge that almost $200 million were distributed to health centers last year to try to increase the capacity for treatment. A lot of that went to staffing and hiring additional addiction specialists, but also making improvements in our data collection and our training. So again, if you are working with people experiencing homelessness in your programs, please make sure that they're connected to a place where they can get medical care and that medical home is really giving them the comprehensive services that they need. I've put some resources down here to help you find a health center, either a health center serving a general underserved population or specifically the HCH programs. So with that, I just wanted to had done a quick snapshot on Medicaid and health centers, and I'll turn it back over to my colleagues to move on with our program.
Okay, thank you, Barbara, and we look forward to you closing out the webinar and hearing more about the recommendations. And so next up, we have Anaji from SAMHSA. Thank you. And Anaji, are you still there?
Hello, everyone. It's a pleasure to be on the webinar. Yes. Can you hear me?
Yep. Yes,
Hello?
we can. Yes, we can hear you pretty well.
Hello, can you hear me?
Yes, we can hear you fine.
Okay. All right, I was talking. Good. Hello, everyone. Good to be here. Just continuing along the lines of the discussion we've heard thus far. It's a pleasure to be collaborating with, national leadership and associations focused on ending homelessness, dealing with homelessness, and dealing with this extraordinary crisis, which, it's described very clearly in the media, so we don't have to really go into big detail about it, except that SAMHSA recognizes the extraordinary situation and that opioids represent a new phase, a new kind of era in the overall substance use disorder problem that we face nationally. We tend to be reminded that there are other drugs of abuse out there, but the lethality of opioids due to the overdose conditions that occur when people utilize opioids in combinations with other substances, and also some of the adulterated types of preparations with fentanyl and other drugs of abuse. It makes it quite difficult for the delivery system to respond in the ways we have in the past. So we're looking at new ways of doing that, and we see data it seems like every week about how this has outstripped other periods in our history in dealing with addiction. So the slide indicates that, more people have died from opioid overdoses than at the peak of the HIV epidemic. So we can go to the next slide. And I mean, we've also seen recently that life expectancy in the United States as a whole has decreased as a result of this. And that's, again, an extraordinary finding, an extraordinary phenomenon. And we know it's driven somewhat or has been driven by prescription drug abuse as well as heroin drug abuse. And as I mentioned earlier, fentanyl, which really has, and carfentanil, which really has no known medical use in human beings. Yet and still, it's in our communities, and it's something that we have to deal with. We know that if you look at this slide, that there are almost 1 million heroin users, but almost 12 times as many people who are abusing prescription drugs. And what happens is that people often will convert from prescription drug abuse when they can no longer get that supply and begin to use heroin, sometimes snorting and then converting to intravenous use. And we've seen this pattern, and SAMHSA is trying to address it through its prevention efforts, as well as dealing with folks who present at various stages with their disorder in treatment settings. Next slide. One thing that we're very clear about is that in spite of what we're hearing about the lethality and the problems, that we do have people who recover, and we don't want to lose sight of that. The SAMHSA is a part of the Department of Health and Human Services. We have a broad framework of an opioid strategy, which includes better data, and often with overdoses, it's not necessarily clear whether it was a suicide, an intentional overdose. We don't know often whether a person who has passed away based on the mortality information that we get from coroners and other county reporters, whether actually drug abuse was the main cause. But we're trying to refine that data collection and also do better surveillance at the local level all the way aggregated to the national level, so we really have a clear handle on what's going on. We want better data, We know that, as I said, the prescription drug abuse has been a driver for the opioid crisis. And so the CDC and our medical academic institutions are training physicians to treat pain in more improved ways, less emphasis on opioid prescribing, clearer guidelines for that, and that's being promulgated. I've mentioned some of our prevention efforts. We know that media campaigns do have an effect and do draw attention to the fact that there's risk and there are alternatives. And of course, you must have your head under a rock if you haven't heard about how first responders are, of course, on the front line and doing all that they can to help reverse overdoses. It's happening in emergency rooms, fire departments, EMS workers, and even lay people who have naloxone and Narcan are being effective in reversing overdoses. But what we're also seeing is a need to connect people to better care once they've had these episodes, because there is a significant percentage of people who will have several reversals and then finally meet their demise when they, after a pattern of overdose reversals, and we're trying to interdict that as well. And of course, the best way to refine our approaches is to have better research, to partner with academic institutions and our research centers at the federal level at NIDA and NIH. Can we move? I think the next thought that I wanted to convey is that, again, it's not all doom and gloom. We know that there are approximately 24 million people, estimates maybe as high as 25 million people who are in long-term recovery from substance use disorders. And a significant percentage of those are persons with opioid use who have had opioid use disorders, been intravenous drug abusers, who are perhaps on medication-assisted treatment and on methadone and buprenorphine, and others who have found their way to other forms of abstinence and sobriety, and that should give us hope. And we do have shifted our focus to recovery-oriented systems of care and philosophy that we're trying to build infrastructure across the country to support. Next, please. At the end of 2016, Congress appropriated almost $1 billion for the expansion of substance use disorder delivery treatment. And through the Department of Health and Human Services, SAMHSA was designated as the lead agency to deploy these funds to state agencies. And that's the key for people to understand. And I in my personal life and moving around in communities, people want to know, how do they access the funds? Well, the key partner for SAMHSA is state agencies who each have received a proportion of the $500 million in FY17 and another $500 million in this current fiscal year 2018, and doing a variety of prevention, treatment, and recovery activities according to their own strategic plans and needs assessments. And they are trying to address this comprehensively. And the best way to connect with these agencies is to find out what their planning councils are doing, who they are contracting with, and where they plan to place the emphasis. Each state gets to make their own decisions and emphasize whether to do more opioid treatment programs, office-based treatment with physicians, large prevention campaigns at the youth and school level, large media campaigns broadly, recovery support using peers. So there's a wide variety of approaches and emphasis, that each of our 57 grantees, including all 50 states and several territories, are utilizing. So let's move forward. Of course, I mentioned earlier our recovery focus, and that means that, that we're looking for strategies that will bolster recovery at all 4 of these dimensions of health: housing, permanent housing, as well as recovery housing, employment, including supported employment, and just recognizing that although people who have these opioid use disorders will sometimes need high levels of care, intense levels of care, hospitalization, detoxification, we know that that eventually their recovery will need to occur in community, and they will need these recovery supports. We call them recovery support services, which can be provided in each of the dimensions shown on this slide. We are especially concerned about in addition to permanent housing, making sure that people have recovery supportive environments in early recovery. As I said, leaving treatment, while in treatment, post-detoxification, wherever they are in their recovery journey, we know that the people need safe housing. And our 2016 U.S. Surgeon General's report emphasized the importance of such housing and recognized that Oxford houses are a great example of such housing with high abstinence rates. And we also know that there are other levels of recovery housing, and the National Alliance of Recovery Residents has codified that very well. And many of the standards that NAR has developed have been adopted across the country. And you can see how many people have been involved in, are currently involved in such housing levels. And for those who are not that familiar with them, those levels include Oxford houses, which are peer run. And then the next level is some level of monitoring, maybe a little less democratic. Level 3, there's a supervision, a staff member. These level 3 has recovery housing that is staffed. And level 4 is actually a treatment setting in which you actually have professional clinical staff involved. And in terms of SAMHSA funding, we're looking for providers who have standards, either NAR standards or something similar, on which we can rely on to make sure that there's quality and oversight of the types of care that people are receiving when they utilize such an approach to support their recovery. Concerns that we have are that, there have been some exploitative actors in the field who have taken advantage, particularly of people who have different insurance packages and benefits. And it seems to be a kind of a gray area where there's not sufficient oversight. And so one thing that SAMHSA is requiring is that when federal funds are used to support housing, that the standards are clearly adopted and monitoring takes place. States are pursuing this in different ways, and I understand that there's legislation at the state and federal level. The federal legislation, I think, is pending at this point, hasn't passed. There haven't been any particular bills passed focused on this, but it is being debated. There are concerns just to make sure that when a person with a disorder goes into one of these or receives the services, that they are not being exploited. In the opioid STR program that I mentioned before, the use of some portion of those grants that the states are managing are allowed for recovery housing, and that's a fairly new development for SAMHSA. And our current focus is on refining what we mean by recovery housing, and working closely with our partners at the Housing and Urban Development in terms of differentiating, for example, recovery housing from permanent housing, making sure that there are adequate standards of practice and the oversight that I mentioned earlier. And probably critical as I come to a close is the infusion of evidence-based practices in this arena, and overcoming stigma for the acceptance of people on medication-assisted treatment in sober housing and recovery housing environments. And as I said, working with HUD and other funders to make sure that such housing has support and it can be reimbursable. Those are some of the things that we're thinking about as we move forward to do our best to confront the current crisis. Thank you.
Thank you, Anaji. You really gave us a great detailed discussion. So due to time, I'm going to go ahead and move on to Marcella. Are you there? From CSH? I know Marcella is logged on, so let's see, we might be having a technical difficulty. Okay, Marcella?
Yes, I'm here.
Okay, great.
Great. Thank you so much, everyone. Thank you to the National Alliance for bringing this great group together, and thank you for the great conversation that we're, having and will continue to have. Really, just starting to sort of put our toe into the water in some of these questions and areas, and really try to come up with the solutions that can help address this crisis. As Anjay said, this is a crisis that is literally so severe that it's bringing down the average life expectancy in the United States. It's a crisis that's so severe, we're losing more people than we've lost at the height of the AIDS epidemic. So really important too, and I'm going to talk about today about how to develop systemic responses to the opioid epidemic, some of the strategies that are being used at the federal level in states and communities today, and then really bring it to that next wave that we're just starting to see of recovery support services and how those are getting out there before we move on to the real specific examples from Philadelphia. So next slide, please. This is just many of the folks that we work with here at Corporation for Supportive Housing. Next slide, please. CSH, for folks who aren't familiar with us, we are a national nonprofit, 22 offices in 13 states with 4 lines of business: training and education for states and communities, policy reform agenda, consulting and technical assistance, and we're also a community development financial institution, or a CDFI. So we work to, at all levels, increase capacity in supportive housing and ensure that the supportive services, as we'll talk about here today, are able to address the needs of the individuals they're serving. Next slide, please. They talk about some of the first wave responses that folks might have seen that are happening in these communities. These may or may not specifically address homelessness, but to be aware, states are working hard at what we call pharmacy benefits and supports. They're trying to look at prescribing practices of physicians. They're trying to do data analysis to see, is there a very high rate of opioids coming from one place? This is something that can often, one, save the state money as well as state lives. It's as simple as most of us, my guess is on this teeth, maybe had their wisdom teeth out at one point, and you were given a 30-day supply of opioids for something that you needed 2 days for. How do we change those prescribing practices in order to make it really what people need and give not so much an opportunity for abuse and addiction to develop there? Certainly for many people, this is not all, but for many people, those were the roots into the initial addiction. Overdose prevention, this is access to naloxone or Narcan. This is something that's coming out broader and broader. SAMHSA has done a lot of support for this through their Cures Act and CARA Act funding. And Narcan, having the access to it, having the training and understanding how to do it is something that I would say every homeless outreach team should have, every shelter should have, every permanent supportive housing program should have. And so getting that broader and out there. And then as Anjay talked about as well, access to medication-assisted treatment. Research has shown very clearly there are significant changes in the brain that happen from long-term opioid use. And so it's going to be really important for folks to be able to engage in recovery, to have access to this medication-assisted treatment, Suboxone, naltrexone, Vivitrol, as well as methadone. Really important point to note for homeless service providers. In order to get on methadone, in order for people to access treatment, you will need some sort of state-issued identification. Identification is a huge issue for people experiencing homelessness, so that's going to be really key. And I just want to highlight all of Barbara's points in regard to the ability to access this treatment for people that are uninsured is incredibly limited. Really encourage supportive housing providers, shelter providers to begin screening for whether or not people are on Medicaid, whether they're accessing the benefits they're entitled to and able to and if they're not, have the homeless service providers be able to assist them to access those benefits. It's great when somebody is finally willing to engage in recovery, but if they don't have that identification, if they don't have access to their Medicaid, then you can really lose that moment for people. So these are some first wave of responses. A lot of work happening in the communities out there. Really excited. Want to move on to some what I would call second wave responses. You see a little bit more of this coming, but not as much, and these are areas that we really want to work on and bring more bring out further in 2018. One is recovery support services, whether this is peer supports. Many states' Medicaid plan cover certified peer specialists. Sometimes that's only for people with mental health issues. Sometimes it's for people with addiction and or mental health issues. CSH has a great Step Up initiative. We're trying to train and organize residents of supportive housing and help them advocate both for themselves as well as for individuals who are still experiencing homelessness or many of these disabilities. Peer supports is part of the recovery-oriented systems of care, a really essential point from Anjay's presentation as well. Supported employment, and then also education assistance, especially for our younger population. They may not want to get into employment right away. They may want to enhance their educational opportunities, recognizing the impact that that's going to have in their long-term financial health. So helping people with disabilities engage in education as well. Broader treatment access. This is again where folks are going to need identification. Folks are going to need their Medicaid, but folks may have the ability to access longer-term treatment here. The American Society of Addiction Medicine, or what we call ASAM, has levels 0 through 4 of treatment. This can be anything from an outpatient 1 hour of counseling a week all the way to months and months of inpatient residential care. Having someone assessed by a trained clinician, having someone being able to access those treatment and services is going to be really important, and we'll see what the impact of that is on the epidemic as well. It's going to be really important that as states are beginning to use through Medicaid waivers and other opportunities, expanding their access to residential treatment, you'll start a conversation in your community about when someone does or does not have that designation of homelessness. So folks know there's the 90-day requirement for that homeless definition, and there's going to be a lot of interesting conversations that happen to think through when do they lose that addiction? When do they lose that homeless designation, and then what does that mean for their ability to access COC or other homeless-related resources? And then finally, we're seeing supported housing that's targeted to people with multiple disabilities and challenges. Some people experiencing addiction, very few, they just have that addiction challenge. Once they can engage in their recovery, they're really ready to go back into the workplace, back with family. You find many other individuals who have multiple disabilities, much higher incidence of trauma with folks with opioid addictions, much higher incidence of serious mental illness, and other chronic medical conditions that may mean that an individual may be a good candidate for supportive housing. Certainly people with that chronic homeless definition will need that possibilities as well. So we're going to shift now and begin to talk about the Philadelphia program. I'm very proud to have been one of the founders of that. One of the pieces I want to highlight is some of the financing on that. How do you fund for homeless service providers, especially providers who are very used to working with the McKinney? How do you fund the services portions of these projects? How do you know what are the right mix of services? So I'm going to talk about a couple of strategic financing models that are needed. These are really community-wide, system-level conversations that need to happen. There's Medicaid, of course, lots of things, as Barbara said, that we can say about Medicaid. One to remember, Medicaid has the deepest pockets. Medicaid also has the most rules and an extraordinary administrative burden. So when I was working at the system, at local level on systems, the question was always, can Medicaid pay for it, and try to fit it into the Medicaid box. What's important to know is that sometimes the answer is yes, sometimes the answer is make a little changes and the answer becomes yes, sometimes the answer is no. So you never want at a system level to be funding something in some of these other ways that could be Medicaid when because you've got that possibility. There's substance abuse block grant funding. As Anjay said, that comes from SAMHSA, that goes to the state. So it's really important to know who your state drug and alcohol directors are. There's a national organization with good information called the National Association of Alcohol Abuse and Drug Abuse Directors. And so where does that block grant funding go, and what does that support? And also think strategy-wise. Is it supporting outpatient treatment when that could really be supported by Medicaid? Is it supporting outpatient treatment just for the uninsured? That can be a really important use of it. Is it supporting outreach? Is it supporting other resources as well? Anjay also talked about the Cures Act. That's $500 million nationwide for fiscal year 17 and 18. There's also a lot of flexibility there. It's going to be also important to see what your state's doing with that funding and make sure that there's accountability built in there as well. A lot of this money is very large and coming through very fast. You're going to want to ensure that it gets targeted and prioritized to the most in need. And then there's the CARA Funding Act as well that came through. A lot of that is going to train first responders for naloxone and naltrexone. Look in your community and see, I'm sorry, not naltrexone, Narcan. Get those mixed up sometimes, forgive me. And it's going to be important to see that police are getting trained in this. Emergency technicians, first responders are getting trained on this. Can outreach workers get trained? Can you have access to that funding as well? So always be thinking about at the system level, what are the resources for services, and are you using the limited funding you have in the most strategic way possible? Next slide. I'm going to skip this one. Anjay talked about this as well. So this is the HHS's 5-point strategy for the opioid crisis. Highlights important, but go on so we can have time for questions as well. And next slide, please. It's important to take a community-wide response. As we shift into talking about the Philadelphia program, I will share sort of the history of how the Pathways to Housing program got started. As HUD was pushing us, and the COC, the SNAP's office, was pushing us to do more, shifting more services funding to Medicaid, it was great to be part of our behavioral health system, where we had not only substance abuse block grant funds, mental health abuse block grant funds, but as well as working with our managed care organization. In 2015, I believe, or 2014, we were able to shift over $700,000 of HUD supportive services money into Medicaid. So I really have to shout out 3 agencies and multiple programs from Horizon House, COMAR, as well as Hall Mercer Community Mental Health Center. They were willing and able to shift their services funding from supportive services to the Medicaid program. That generally increased their funding, significant changes, but were able to sustain the individuals they were serving and take more challenging people because they were part of that Medicaid mix. And then we were able to take those saved funds and start the program that you're going to hear about today from Pathways to Housing to address a need that we were seeing, Philadelphia was seeing, through its homeless death review process. So just want to highlight, especially for the system folks here, think about the strategic financing, think about the way your money is being used, think about it as there are ways to shift some funds in order to expand the capacity here so that we have the options that we're going to, I believe, hear about now. Next slide. And this is just my contact information. Any questions folks have in regard to what we're talking about, please feel free to reach out either over email or via Twitter. And I'm excited to hear how the Philadelphia project is going. Thanks, John.
Okay, and thank you, Marcella. And for the sake of time, I will move ahead to David. And after David speaks, Pathways to Housing PA and Prevention Point, they will also be presenting. And so you can just immediately follow David as representatives of Philadelphia, as we labeled it a city in action. So thank you. And David, are you here? David? He may be having technical difficulties. Hold on. Okay, so I might have to reach out to David via email. So what we will do is then we'll just move on, since Marcella set up Pathways to Housing, the project there. We will just move on to that, and in the interim, I will contact David, and perhaps he can just close out. So Matt and Katie, are you both there?
Yes, I'm here.
Okay, so please begin, and thank you for being here.
Hi, sorry, my computer froze right as I was trying to start speaking. Oh God, and the whole thing shut down. Okay, so I just lost the visual on the slides, but can everyone hear me?
Yes.
Okay, so I'm gonna have to do this blind for a minute, so I apologize. Thank you everybody for having me here. My name is Kate Perch, and I am the housing coordinator for Prevention Point Philadelphia. And as it's been said, we're considered a city in action, which we're really proud of. So Prevention Point for 25 years has been the city's syringe exchange program. Our current sweep of services includes much more than that. We provide a variety of public health and social services interventions to meet the needs of Philadelphia's addicted population. We are located in the Kensington neighborhood of Philadelphia, which, as many of you might know, is considered sort of the epicenter of the drug epidemic on the East Coast. We have a very large open air drug market. And what I want to talk about just briefly is sort of our experiences at the front door of initial engagement with homeless folks who are using opioids and connecting them into housing. And we do that in two primary ways. So the first is that we, thankfully, through the Department of Behavioral Health in our city, have a homeless outreach team that is particularly targeted to this neighborhood and this population. And what that means, some of the stuff that Marcella already highlighted, is that we really try to be the bridge, not just to housing, but to drug treatment services, to overdose prevention services. We really try to kind of look at the holistic needs of this population. And it's been a very successful model for linking to people who might not otherwise get sort of into that front door of services. The other thing that we have been doing since 2015 is we operate a small emergency respite shelter. We just recently became year-round. We used to just be a winter program. We operate 30 beds with 10 overflow beds in the winter. We've served approximately 160 people through that project, with about 60 successful permanent housing placements, and we'll talk a little bit more about what those look like, including to organizations like Pathways to Housing. I think it's important to note that we are the only syringe exchange in the country that we know of that is doing this type of shelter and outreach work, particularly with city funding. And I think this is really important because we have a unique relationship, in programs like syringe exchanges, like drop-in centers, which we do operate, I think are a really important first step to engaging folks. We are obviously harm reductionists. We're very low threshold. So we really try to meet people where they are, create as few barriers as possible. We don't require ID for most of our services, except the drug treatment, like Marcella mentioned. And I do want to point out how important that ID piece is for that. Our shelter does not require ID. We don't do drug testing as a part of our program. So we really, really try to be as low barrier as possible. And that's how we're able to successfully transition some of our folks into long-term housing programs like Pathways, which I'm going to let Matt talk about.
Great, thanks, Kate. So my name is Matt Tice. I'm the clinical director with Pathways to Housing. We've been around since 2008, and serving this population is not new for us. We've always kind of integrated them within our services of doing housing first, providing long-term permanent supportive housing to individuals moving from the street. But what we did do after kind of recognizing some of the severe need is developed a highly specialized clinical team to support individuals with opioid use disorder. And the majority of those individuals really were referred directly from Prevention Point. And a lot of them, the remainder of those were still referred over through some of the different city agencies, but that relationship that we had with Prevention Point, with folks who were engaging with the syringe exchange, with wound care, or longer term outreach, was invaluable for us to be able to, first off, be able to get into some of those communities, establish relationships, and then help them transition into housing. And so we work from a sort of community treatment model, which means that we have multidisciplinary teams to support those individuals once they do come into housing. We don't have the expectation that folks need to stop using, although we are always offering all of the other options that are available to them. We also do make sure that we have a fully integrated healthcare clinic that's on site. It's actually a satellite site of a federally qualified health center, and this primary, and it offers primary care. There we're able to also offer buprenorphine, Vivitrol, and plenty of referrals to methadone treatment as necessary, in addition to all of the other things that would come along with regular primary care, which have also been incredibly important for the people that we're serving. We also, so our teams are very focused on both home-based and community-based case management and care coordination. So it's all through the lens of harm reduction again, but they're making sure that they are going out to people's homes, or in other instances going out to the street, going under the bridge, going to the street corner, and offering them whatever is necessary for them at that point, engaging them at where they have the need. And so we can offer substance use counseling, mental health counseling, nursing, psychiatry. All of that is part of our treatment teams. You go to the next slide. So in the first year, so we've only been around with this particular team for about 1.5 years. And in that time, though, we have been able to boast about 100% compliance, or 100% housing retention rate, which we know is phenomenal. We have really been very proud to be able to keep our individuals in housing, especially in the midst of so many of the different severe things that they are facing, or what they came to housing with. I don't want to just paint an entirely rosy picture that this means that the person comes into housing and immediately there's no problems whatsoever, though. What it does mean is that there's very intense involvement from our clinical teams and support from our, we actually have a whole housing department. Our housing director has very close relationships with all of the independent landlords that we work with, because this is not a single building, it's all scattered site across the city. And so when problems do come up or issues do arise, we immediately get involved. And we have had people that have had to move, or maybe that there's been something that's occurred in a particular apartment, but what we do is not say, well, you're done, you're going back to the street now. Instead, we need to strategize, okay, well, that didn't work, or maybe that neighborhood, or the combination of all of the other services that we were offering to you at that point was not effective. So let's look at a different approach. We found this fall that we had about 52% of our participants were receiving medically assisted treatment or were abstinent at that time. The majority of those were not engaged in that when we first met them at that initial referral level. And so we were able to help them get connected up into those services. And these numbers do fluctuate from time to time, but the trend has absolutely been upward through the whole span of the program. So we've been really, really glad to see so many people engaging in medically assisted treatment. We also do make sure that 100% of our participants are receiving naloxone or Narcan training, as well as everyone is all working on developing an individualized overdose prevention plan or a overdose prevention goal plan. And so that's going to be different for every single person too. So maybe somebody who is sober at the moment or longer term sobriety, what are the strategies or plans to maintain that or to prevent relapse? But it's all kind of tied back again to overdose prevention. And we're so focused on safety for them because that's a major concern for this particular population. When overdoses do occur, and they do happen, the support team is then able to jump into action, and we highly individualize the responses about what they need to adjust or change around the overdose prevention plans. I'm going to hand it back to Kate, though, here. Next slide.
Yeah, so I just wanted to highlight quickly a couple other partnerships with some long-term housing programs that we have found can be successful for folks that are coming off of the streets, coming out of some of our encampments, and also out of our shelter programs. So first, the city, in partnership with the Department of Behavioral Health, has a pretty fantastic recovery program that we refer to as the Journey of Hope Project. This is long-term, high-level residential treatment. And I think what is particularly unique about this is that it's 9 to 12 months of that residential treatment with a direct link to permanent supportive housing at the end. And what we have found is that for a lot of our folks who are looking for that extra structure, who are committed to engaging in a recovery process and really want to separate themselves from the neighborhood and the places that they've been engaging in their youth, this can be a really, really great program. And I'm also happy to say that they've recently initiated an overdose prevention training for all of their participants, which is key, as I think both Matt and Marcella have mentioned. Rapid rehousing, surprisingly, we've been happy to see that for some of our folks who are more stable, who have entered into recovery, or who have worked out a way to manage their use so that it's not necessarily making it impossible for them to manage their funds, manage the behavior in their apartment, that this can actually be a good model to quickly get folks out of some of our more temporary housing and into their own apartments. There is limited support for relapse and money management issues and linkage to mental health and trauma-focused care, but like I said, for some of our more stable folks, this has been a really good option. And then, of course, permanent supportive housing, we're all very familiar. What we have found is that programs with the more enhanced the support, the more successful we find our folks tend to be. So really looking at wraparound level services, recovery support services, not necessarily on the level that Matt described in the Pathways program, but just something that provides a little bit more oomph, I would say, for folks who may be, especially those who are new in their recovery and are still working through that process. Next slide, please. So Marcella actually hinted on a lot of these things in her presentation, but Matt and I just wanted to highlight what we see are some opportunities and challenges in working with this population and moving folks into long-term housing that we've seen. So that first one that I think, Marcella really did talk a lot about is the importance of meaningful activity and making sure that we are providing community involvement, job training, educational opportunities. I think for some of our folks who enter into the recovery world, we need to broaden and really look at the holistic notion of recovery and make sure that it's not just about maintaining your sobriety, but really giving people meaningful opportunities to engage in their community, to build their skill sets for independent living, and really take that holistic approach. And I think Matt's going to talk about the next few.
Yeah, I had mentioned earlier with the whole aspect of maintaining people in housing, it does not necessarily mean that we don't encounter problems. We absolutely do. And we meet with it. We meet with our housing department on a very regular basis. We maintain constant communication with our landlords, with our the property managers, everybody that is working individually with all of the participants. And there's a series of things that kind of become a greatest hits of what are coming up on a regular basis with serving a lot of these individuals when they're transitioning, especially from longer term use, and that they're still active in that addiction too. And sometimes it's things like dealers coming into their units, or maybe it's other things like potentially an apartment could be viewed as a source of income. And immediately we are trying to spring into action, similar to what I said about overdoses, to address those behaviors, to find out how to eliminate them. And then sometimes it does mean that we may need to move that person, or we might need to suggest, all right, this is pretty severe. How can we come up with a different idea? So maybe it's starting over in a new place, or maybe it's potentially going into treatment. It's not at all forcing them to need to go into a new place. But what we have found is that some folks get overwhelmed with, okay, this was too much for me. I didn't know what was going on. And then that's a really, really opportune time for different kinds of interventions to be able to be implemented. What we do also see is that it can be both a strength and a challenge, is the informal communication network amongst this population, is that people all talk. And if you do one thing for this person, then they're going to expect that you do it for them. And we have to treat everything so much case by case. If you just have an across the board policy and say, this is how we respond to this particular situation, then you're going to be bound by those things. And every single day we encounter new things that we had not thought about. I learn new things all the time. Kate and I teach each other stuff across our agencies, and so we have to be flexible. We have to be able to think on our feet. And that applies also to the parameters of people's own individual situations, the degree of trauma that they're facing, the circumstances of homelessness, the circumstances of substance use, on and on and on. And so we have to be clear in how we communicate about that, and also noting that there's going to be variation in how we respond often. It's really crucial.
Yeah, I think this really gets to what a couple people have mentioned, which is the importance of having a community level response and really collaborating at all levels, whether you're at the front door, whether you're the treatment provider, whether you are, in the case of Pathways, sometimes all of the above, really making sure that we're all talking to each other. Just really quickly want to highlight our last 2 points. I know everyone else has said it, but I do think it's important to keep stressing the importance of safety planning and overdose prevention. I think the more that programs can continue to remove the stigma that I do think exists still in some recovery communities talking about relapse, this is a population with which overdose can be fatal and relapse can be fatal. And I think anything that all of us can do, from outreach workers to housing providers to primary care providers, to keep stressing the importance of having these conversations openly. You see research that indicates it can take anywhere from 8 years, multiple cycles through that relapse recovery process before somebody reaches sort of true sobriety. So it's so important to stress that. And with that, just making sure that case management support and recovery supports are available to people regardless of where they are in their use history. So making sure that if someone relapses, we keep continuing to offer them those same services, those same supports, and recognize that they are on their own individual trajectory with their use, and continuing that conversation to help them make the best and most healthy decisions for them in that moment. So thank you, everybody. We don't have our contact information on these slides, but we can definitely definitely get that to folks if they need it. And we really appreciate the opportunity to speak with you. Thank you.
Yeah, thank you, Katie and Matt. And I'll make sure that people have access to your contact information. And thank you so much for giving us insight into your program. And so we're going to just flip back and let Dave Holloman close out from the city of Philadelphia. He was on the line, but we just had a few audio issues. And so I will let Dave begin, and then we will close out the webinar with Barbara and then open it up for questions. Okay, David, are you there?
Yes, I'm here. Can you hear us?
Yes, wonderful.
Hey, hi, good morning. I'm here with my colleague, my director, Liz Hurst, who has been at the forefront of this agenda. And thank you again, everyone, for this rich discussion, a much needed discussion. And Philadelphia has been doing some phenomenal work, and along with the providers who you just recently heard from, Prevention Point and Providers. So I want to really turn it over to Liz to talk about, from a leadership perspective, what Philadelphia has been doing around housing individuals who are struggling with this opioid epidemic.
Great. Hi, everybody. So great to hear from Katie and from Matt, who are really on the ground in this work and leading the charge. I think the key for us here is leading from the grassroots up. And the effort of the city's Office of Homeless Services has been to follow the lead of the providers who are actually on the street working with people who are struggling, because this is uncharted territory. We haven't been here before, and so we have to learn organically what works. Just a little bit of context about Philly. We're the 6th largest city, and still today have the lowest rate of street homelessness among the major cities, even though we do have the largest poverty rate. And we've been plagued with this very abundant supply of cheap, potent heroin, often cut with fentanyl, and just closed out 2017 with more than 1,200 overdose deaths, about 4 times our murder rate. Talk about dark statistics. Unfortunately, one of the dynamics of the crisis that you really heard Matt and Katie responding to is that the nexus of the opioid situation has happened in one of our highest poverty communities. It's already a community that was plagued by a high rate of homelessness, infant mortality, human trafficking, and drug trafficking. And so this is just layered on another crisis that has that's plaguing the city. And so it's very important that the services be local and be culturally relevant and sensitive. And so one of the things about Prevention Point is that they have a large bilingual, bicultural staff, because one of this is largely in the Latino community geographically in Philadelphia. And we started out with a very large encampment in a railroad bed. And now we have several other encampments under railroad and car bridges. And I think one of the real frontiers of this is what the encampment means, because there's a social structure and an order. There's the guy who sort of runs things. There's a quote unquote doctor. And I think that really understanding the dynamics of the encampment seems to really be critical. Philly started in this process with an opioid task force, and it's really, I think, as we've heard throughout this webinar, the intersection of addressing the opioid crisis. And some people who enter into this addiction do have means, and they have families who with some work will take them back, and others who are already very poor and dislocated, unemployed, and suffering with multiple disabilities and long-term homelessness. And it's kind of sifting all of that out, as I think we've heard from our providers. So we have done many of the things that we've heard about, trying to reduce the supply of prescriptions for opioids, reducing deaths through widespread availability of Narcan, increasing availability of treatment, and increasing the availability, particularly of medication-assisted treatment. But it's really that nexus between homelessness and the opioid crisis that Pathways and Prevention Point talked about. Just to lift up some of the things that we have learned and that we're continuing to advance and grow based on their experience. One is making it as easy as possible for people to come in. I think one of the dynamics is that everybody wants other people to get treatment. And what we found is that isn't necessarily the front door for people, that is coming in to get food, to get wound care, to get primary care, to get needle exchange, to have a place to sleep that's safe, that kind of low barrier respite. That is the hallmark of the Prevention Point site that we have, that's really been so successful in getting people in. And it's really meeting them where they are and making it possible for them to come in. And then I think, as you saw from the stats that Katie and Matt showed, is that once people are in, they get their basic needs met, they can breathe a little bit, that then they can start to think about these more complex problems, like where the heck am I going to get my IV, and how am I going to reconnect with family, am I going to get treatment? But it does seem to us to be impossible to address those needs, the need for recovery, until your other basic needs are met. And I think that that is really the strength of the programs that you heard about today. The other thing I think that we've all talked about, and that is to, again, to state the obvious, but it's still in such short supply, is the end game of a place to live, especially for people who are extremely poor. We heard about rapid rehousing. Many people do reconnect with families. About 15% of our population comes from out of county and out of state, and they do often have resources. But for those folks who really don't, the magic ingredient, the special sauce, is hope. And there really is no hope unless people have the sense that there will be a home at the end of all of this. Philly is now exploring a safe injection site, again, kind of building on the model that Prevention Point started 25 years ago, of meeting people where they are, harm reduction, giving them what they need, and then building from there. And we're really proud to build on the success of Pathways. They've got 60 slots funded through the COC, and we self-funded through the city an additional 15 slots. We believed not only was it a cost-effective intervention, but that it was a humane and effective way of getting people off the streets and into the kind of care that they need. So we're optimistic, if somewhat overwhelmed by the magnitude of the crisis, but I think it's the work of Pathways and Prevention Point and our amazing homeless outreach teams in the partnership with the behavioral health folks that really gives us hope that the more we're able to mobilize resources, that we are going to be able to offer a lifeline to people who are deep into this disease.
Oh, and Liz, and that is wonderful. And I don't want to rush you along. We most certainly appreciate your contribution, but it is 12:09 and we have another speaker, and so many people have asked questions, and so I am going to thank you and move on, and we really appreciate the information about Philadelphia. And Barbara, I don't want to cut so much into your time, but we have so many questions. So if you can begin with the recommendations, and we may you may have to just cut to your major points, because we really do have excellent questions, and I'm going to try to get to as many as possible. So I really do apologize to have to rush a couple of the panelists, but thank you.
Sure. So let's just plunge in. If you can do the next slide really quick. I wanted to make sure that people were aware that the president had put together a commission to analyze this issue, and they have recently issued a report. I included a link to the report and this commission's information here below. If we can move to the next slide. The report covers a number of focus areas. And so I want to say, though, that SAMHSA folks and Anaji had already covered a number of these. These are the areas that are divisions in the report, but they also align with some of SAMHSA's priorities. So I think that works, but just so you can get a sense of the breadth of the recommendations. In the next slide, I just wanted to highlight some of the areas of the report that are going to be particular for people who are serving individuals who are homeless. We focus a lot on workforce because we know we need a lot in the delivery of care. We know we need a lot more in the quality of care, and I really can't emphasize enough quality standards, really making sure that we are connecting people and that we have access to comprehensive and high quality treatment. So the report includes recommendations to be able to get us to a better place there. Recovery support's got a brief acknowledgement, but I think that some of the discussion that we've had today really emphasizes how much support people need to be able to be successful in attaining and retaining recovery. We've talked a lot about naloxone, so that's really helpful for EMS personnel, but also as housing providers and other providers of services, having access to that is really key. Pain management. I know a lot of the folks that we are treating do suffer from chronic pain. So figuring out how do we manage that pain so that people can be healthy and successful. And then I think we've talked about some mass media campaigns and really making sure that we're combating stigma and doing that from inside our community as well. So I think that we've mentioned that, but I really want to go back to that because it's so important. In the next slide, I just want to mention really quick just some of the gaps in the Commission's report that weren't really covered or acknowledged. There was a focus on block grant funding to states for substance use disorder, and in fact, those were the first couple of recommendations. But there was no inclusion and recognition of the role of comprehensive health insurance that ends up being able to connect people to a full range of care that they need. I really want to emphasize the role of Medicaid and other health insurance options. Also, I just wanted to talk too that the report has a near exclusive focus specifically on recovery housing. And we know, and I'm really excited that Liz and Matt and Katie talked so wonderfully about the role of supportive housing, and in particular for the population we're serving, we know we need a broad range of housing options, both recovery housing and supportive housing, because people are going to need things tailored to their needs. So really want to emphasize that was missing in the report. Supportive housing was mentioned, but really only in the context of child welfare. So we know that particularly in this community that that's a broader issue. If we can go to the next slide. I just want to wrap up by talking about some advocacy areas. So we've covered a lot of information on this discussion here, but there's so much more to talk about. Just some of the things, if you're looking for areas where you can be more active or be able to participate in making more improvements, this is just a handful of things. But one is really looking at how your own program is designed. We've talked about ID requirements. If you're a program that prohibits people from having medications, that's going to be a real barrier to being able to serve people with opioid addiction. And how are you connecting people to care or partnering in ways that you can to be able to serve your clients? But at the broader level, either at the federal level, state, or local, we are just trying to expand a treatment capacity that connects people to high quality care. Again, I want to emphasize quality standards, but I also want to talk too about Medicaid, safety net programs, and a lot of things that are facing some tough decisions in the policy arena, and we are looking at efforts to reduce these areas. And so if there's any effort that you can do to push back against those cuts, either at the federal or the state level, we also know that housing is critically important to the supports that people need. Again, a broad range of options to include supportive housing. And then thinking about how we can extend Medicaid. I'll come back to Medicaid again. We know that that's a good connection to treatment. Block grants are not a replacement for a comprehensive insurance. So thinking about how we're making sure that people are getting the benefits that they need as well. And then if you've got opportunities to be able to improve the criminal justice system and participate in those reforms and making sure that people aren't being incarcerated for addiction, we've got more and more research showing the effectiveness of diversion programs in getting people into treatment. So with that, it's a broad range of things, but we've covered a lot here today. I look forward to continuing this conversation. The work is not done. So at this point, I know we've got a lot of questions and appreciate this discussion today.
Thank you, Barbara, and thank you to all the panelists. Due to the time, I am going to move forward to questions, and I will say that we do have quite a bit of questions, so we will not be able to get to all of them. However, you can certainly contact me, and I will get the answers. The staff, we will definitely work to get the answers to you. Yeah, we'll gather them and we'll send them out. So, so this is open to the panelists. So let me start with one of a common question that we received a lot. And so, if anyone on the panel could discuss any data regarding the opioid crisis and homelessness for different populations. So they want information like, what do we know about vets, families, pregnant women, youth, and young adults, seniors, and persons with disabilities? Just kind of wanting to have an idea of the breakdown. And I'm not sure, does anyone have that information? Brittany might know, or Samson may know. Okay. Okay, so I don't hear a response yet, so we can work on getting that answer to you, because that's a pretty that's a prominent question. So here's another question that we received. So stigma around substance abuse was mentioned, but can providers discuss strategies for overcoming that stigma? And this is probably more for the Philly folks.
Yeah, so I mean, one of the things that we've done is, and I think I saw this in Marcella's presentation too, is making sure that we are really utilizing our peer support specialists, and that they are partnering with all of our participants really closely. And we actually, in addition to having a peer support specialist on each one of our teams, we have a whole department that's focused on community integration. And we are always looking at other ways to help engage this population and plugging into a whole wide variety of other ways out in the community. So whether or not that's houses of worship, it's just other local resources, it's other things like that that help them feel a little bit more connected in a local sense. And even if they may, I think it's also empowering them, but then also when they're going to these other places and we advocate on their behalf, helps bring that stigma down significantly. And we do it in a larger sense in advocacy too. I'm speaking on a regular basis, going to local politicians and other community groups and talking about what people are facing there, and the need to recognize our brothers and sisters that are facing all of this. And the truth is that so many people are dealing with opioid addiction. It's across the board. And so I think that it's in the shadows, but it needs to be talked about really clearly.
Yeah, and this is Dave Holloman. Also, to follow up with Matt's point, Chandra, I think a lot of, and I like to quote one of our colleagues at the Behavioral Health, Roland likes to use the term a community of recovery. One of the things that we have been trying to do is really going out educating various communities. I think there's a stigma that is attached to opioid and individuals who are struggling with heroin addiction. And so really educating community on the difference of these things, where many of these opioid issues starts with, young athletes. You may be a parent that has a kid that is playing a sport in high school or something, and you have a doctor that overprescribed. So really educating them on the difference and what leads to the heroin use is very important. The other thing that we have been trying to do is educate our political leaders. There's opportunities right now because of the use of the opioids and the crisis that's going around. So really educating the political leaders to really take this as a serious. It takes will to go and talk to your constituents to say, these are issues that are in your community, and here are solutions to how to be part of the solution to help your community recover. So really, going out by individuals, groups, civic organization, and really having an educational campaign on the importance of identifying opioid use and making that clear distinction between opioids and heroin and other substance abuse that leads to some of these fatal overdoses.
Okay. I think this is Kate from Prevention Point, and just really quickly, I also want to highlight that the other thing we found helpful is giving community tools so that they can participate in the response. So that's making sure that neighbors have we have a homeless outreach hotline, making sure they have that number so they can get assistance to folks who are homeless, training everyone and everywhere on Narcan and overdose reversal. So really giving people a participatory role in addressing the issue, I think, is also really important.
Okay, and I'm going to ask a follow-up question, and then we're going to go back to Britt, because she actually did have some data for the first question, and we'll kind of go quickly on these two. And again, we will follow up with the questions. I'm just looking at the time. And so if someone could discuss how to reconcile housing first to harm reduction with abstinence-based recovery housing.
So,
Marcella, yeah, I'm going to.
Oh, Marcella, oh, I'm sorry. Go ahead.
Yeah, let's jump in on this one. So,
yeah.
We really think about this, and I think about this in terms of SAMHSA's recovery-oriented systems of care. Recovery-oriented systems of care is a big phrase. It means a couple of really important things. It means no wrong door. So it means whatever door people go through, they get the resources they need. And that may be, Matt gave an example of you'd like to get somebody to treatment, but they're hungry right now. And so we're going to focus on that and build that relationship. And then when they're ready for treatment, we're going to facilitate that process in any way we can. It's important to think about this as from a systems perspective. Every community needs housing first. Every community needs recovery housing. Every community needs these treatment access. How much they need of each is something that we're just getting to the point of having those numbers and information. And there also needs to be clear clear glue that holds these different pieces of the systems together. So, Katie and Matt talked about when people that are in their apartments or people in their respite are ready for treatment, they have a really specialized treatment system in Journey of Hope they can take them to. When somebody's, falling out of a recovery housing, we don't want them to fall into the homelessness system. We want them to fall into a safe haven, and we want them to fall into something that will work with them in regard to where they are. Folks in the homeless system have learned for a long time about principles of motivational interviewing, principles of recovery, principles of outreach and engagement. It's really meeting people where they are, and don't just think in terms of your agency. If your agency doesn't do what somebody needs, figure out how to get them to the next agency that does. And that's really where the COCs come in, and really a systemic response can come in that allows all of these different options and opportunities, but make sure that you're, as much as you can, preventing homelessness as well as ending homelessness. Don't let people, no matter where they are in their recovery journey, fall back into homelessness. Make sure that they're able to move through these different pieces to address their needs.
And Matt, were you going to comment?
I was just going to say one quick thing, that I think that harm reduction is incredibly inclusive on its umbrella, that it includes things like abstinence-based all the way to things like syringe exchange. And it's just incredibly important to still be as inclusive as possible from the harm reduction side. And what we've appreciated so much is also being able to have really great relationships with abstinence-based programs like Journey of Hope. I'm echoing what Marcella was saying, but I think that harm reduction is a very inclusive umbrella.
Thank you. And so we'll go back to Britt. Britt, are you there? Did you want to tackle the first question?
Yeah.
Okay, thank you.
Sure. So I don't have a great answer. Again, we don't have national data, but as far as subpopulations go, HHS, and I'll put these links in the chat box. HHS did some research on youth experiencing homelessness and their drug and opioid use that was centered in LA. So there's some research there. The Veterans Administration recently conducted an expert panel on the needs of veterans experiencing homelessness who struggle with opioid misuse. So there's some great research there. And Marcella, thank you, sent me the City of Philadelphia Homeless Death Review report, which maybe we can send around in the follow-up materials from this webinar, because they do a really great job of looking into the causes of death among people experiencing homelessness in Philadelphia, which sheds some light on the impact of the opioid crisis there. So again, no national data, but research studies do tell us quite a bit about what the opioid crisis is looking like and how it's impacting people experiencing homelessness.
Yes, if I could add to that, this is Onaji from SAMHSA, that I certainly agree. Our national surveillance doesn't offer that type of granular detail in general. However, I've been very impressed with a variety of academic centers who have researchers who are very carefully looking at the opioid crisis within their states, down to the county and local and provider level. And we're beginning to do some rapid cycle evaluation of our grantees, and we'll begin to have that. But I think for community providers, a key partner is the state university or private university who has researchers who are investigating the opioid crisis.
Thank you. So I think we have time for another question. And I believe someone asked about, if we could discuss why everyone who uses opioids don't get addicted. That was the question. Let's start. Yeah. Yeah, who uses opioid get addictions. And yeah, and so people just kind of wanted to understand that.
This is Onaji again. I'd encourage people to look at the Surgeon General's report, which is a free online publication, Facing Addiction 2016. It's pretty up to date, has a neurobiology section. And just one really clear principle is that there's a difference between physical dependence on an opioid, which a person who's on pain medication can develop and still not be addicted. Any of us could have pain and get prescribed, become dependent, but not develop the preoccupation, not lose complete control as you see in addiction. There's a real stark difference between the two. These substances are powerful and have to be carefully utilized and used as prescribed. And when you go off that to what we call misuse, there's a real potential for addiction. And of course, there are a variety of routes to addiction, including prescriptions and including other substances. And you know, certainly when a person starts to inject an opioid, you know that you're in a very dangerous situation.
Okay.
This is Kate from Prevention Point, and I want to highlight too, and I know SAMHSA has some materials on this as well, that part of the reason that so much of what we talked about today was about a holistic response to somebody who has been addicted to opioids and is now homeless is because oftentimes there's a long history of trauma and other issues that may have led to the person entering into the addiction. And so I think it's really important, you know, part of this is this larger conversation that I know all of us as providers have been a part of in the past, to really think about what were all of the pieces that might have been missing, whether it was housing stability, job stability, education, family connections, prior to a person ending up on the streets. And really making sure, and so I think that's another piece, and I know SAMHSA does have some really great materials around the intersection between history of trauma and substance use, and I think that's really important as well.
All right, and we have maybe another minute. I'm going to ask a quick question. This is for Barbara, if you can answer it quickly, but we did receive this question. So how will the work requirement directive from CMS today impact the homeless population and their eligibility for Medicaid and treatment?
Good question, and I think that it does have the potential to serve as a barrier to accessing the benefits to Medicaid. We know that health insurance often provides the stability and it provides the access to the treatment needed so that people can be well enough to then regain access to work. So I think that we're going to see this be a stumbling block. If you are in a state that is considering work requirements, please be a part of that discussion to possibly mitigate those decisions. Again, these are state level decisions, even though the federal government has put out guidance. These again are still state level Medicaid specific decisions. So please be active in this area. Thank you for that.
Okay. And thank you everyone for participating in this webinar, for joining in. We had a great discussion today. We had wonderful panelists. Please view my contact information on the screen. Please feel free to contact me with additional questions, and I will certainly get them to the panelists. Everyone who participated today should receive the slides and information package probably by sometime next week. And I believe we will have this on the web, so you'll be able to review the webinar again. So thank you again for everyone for participating today. Thanks. Bye-bye.